Reminders. One, we do have you were emailed a copy of the rules for the committee. Those have not changed. If you have any questions, please get in touch with me or with Pat or. Okay. Any bill introductions this morning?
Thank you,
Senator Clifford.
I'd like to introduce 26 RS 2651 on behalf of the School Nurse Association concerning use of nasal epinephrine in schools.
Okay. Any questions about this bill? Any objections? Seeing none, it has been introduced. Is this going to be a committee bill?
Committee bill. Thank you, Madam Chair.
Thank you. Committee, today we have a presentation from Secretary Janet Stanek from KDHE. Welcome to committee.
Welcome back, everyone. Thank you. I am Janet Stanek, KDHE Secretary. Today I'll be covering two of the three divisions that we have, Public Health and Medicaid. I have members of my team here to help me and my legal counsel just in case something comes up, and this kind gentleman's going to advance my slides for me. Here it is. Is this it? Or you want to do it that way? Okay, great. So the pages are numbered. Interrupt me. Sometimes I tend to talk fast, so I don't want to bore you with details, but we'll do some overview remarks. I'm going to talk about the grant we received recently, the Rural Health Transformation Program grant, Public Health Overview, and Medicaid. So our mission is to protect and improve the health and environment of all Kansans. There's our organization, Public Health, Environment, and you'll hear another committee hears that overview, by the way, on environment, but here to answer questions in case anything comes up. And then the administrative office, or the office of the secretary, houses legal service, budget, management, procurement, IT, human resources, and communications, and it will soon house a new division under my office called the Rural Health Transformation Office. So our goals, and we've done really well on sustaining this. It's recruiting and retaining all levels of staff to carry out our mission. In our agency, we've put a lot of effort into personnel recruitment, retention, paying attention to people, and managing. And we've got a great story there. We have to meet a lot of legal and legislative and federal requirements. As you know, we're a very big regulated, and we regulate as well. Partner engagement continues to be the story of our success. We align, we fund, we leverage resources amongst our parties, and that's been a mission of mine since I started. We can't do this alone as a state. And then we've also gotten much better at interagency, our own divisions talking to each other, and then within our agency, and then interagency, ag, KDADS, transportation, and other agencies. We try to really work together and align our goals on that. On page 6, you'll find the annual reports that we are legally required to report to the legislature. In public health, the Pregnancy Maintenance Initiative Program, Teen Pregnancy Targeted Case Management Annual Report. In healthcare finance, that's DHCF, that's the Medicaid program. The annual STEP therapy report, which is related to drug use, drugs and complex medication oversight. The HCAP report is the provider tax report. You'll hear about that related to money that goes into a tax that's given to put upon providers and hospitals, but then also recouped. We get matching funds from CMS, and then money goes back into the state coffers to help support the Medicaid provider reimbursement program. And then biannually, we do a diabetes state report. Recently, you've heard in July, there was an announcement by the federal government, CMS, that there was going to be an opportunity for a Rural Health Transformation Program grant. It started out as a Rural Hospital Transformation Grant. That changed during the budget negotiations at the federal level. The governor is the recipient of this grant, and she has designated KDHE to be the lead agency. This interagency team we've created is led by myself and Secretary Howard. I know you heard from her a little bit yesterday, and then key personnel from both agencies. We have signed a memorandum of understanding with University of Kansas Health System, but the Care Collaborative Division. They will support they supported the development of our application, and also the stakeholder engagement process that was a major requirement of the grant. The governor created also what we're calling KREA, the Kansas Rural Health Alliance, Innovative Alliance, which is a group of stakeholders, which will be an advisory group to the state on initiatives that we choose. I will tell you, and I'll get into this a little bit more, we did meet with CMS, and I have more information on how that's going to work on their end. So the timeline, this was like in.
Excuse me,
Yes,
Madam Secretary. Just the committee, this document can be found under documents as opposed to testimony. If you're looking for it under our. Okay, thank you.
And then we'll be willing to share anything else that comes up today. This was a record, I guess, execution related to this grant, to the point we didn't even know if some states were going to try to apply for it. The application was released on the 15th. We had to submit a letter of intent. We had to have a number of signatures from the federal delegation, the governor and others, et cetera. And then we did conduct stakeholder meetings. KHI, Kansas Health Institute, helped facilitate that. We submitted the application November 4th, which was like a day ahead of when it was due. Fast forward, we were advised by CMS to budget for $200 million. Some states, when they got their award, were given less, some were given more. Kansas was the 6th largest recipient. We were given almost 22 million more than the 200, which is really great. That is for year one. This is a recurring grant that we have to apply for every year. So it's kind of ours to lose if we don't make the progress and get to the initiatives and show that we're transforming the rural healthcare delivery system. And I'll emphasize that because this is not about one organization. It is about the system back to our multiple stakeholders, not just hospitals, not just nursing homes. It's FQHCs, it's provider offices, it's name your clinic, and everyone that touches the healthcare system, behavioral health and others, will be impacted by this. CMS then was responsible for scheduling a meeting with states that were given the award. It was called the post-award discussion. We had that discussion on the 12th, this week, on Monday morning. We were advised that our entire application was approved. And if you get a chance to peek at that, you'll see many, many line-itemed initiatives spread out by quarter over the coming year and then going forward. We learned all now what we're required to do. We cannot, even though we were approved, everything we do now has to be rebudgeted. We have to incorporate the 22 million extra into that, and we have to line item to the level of, we learned, we had office supplies as an example. Now they want to know what kind of office supplies. They want to know if it's paper, pens, or whatever. So it's that detailed. So back to the CARE Collaborative at KU, they're helping us with this. We are partners. This is a team sport. We have to return that information with our revised budget by the 30th of January, and then CMS usually has a 45-day turnaround, and they are committed to turning things as fast as possible. They are still in the process in the Office of Rural Health Transformation at the federal level, hiring people and whatnot. So they seemed, the good news, very flexible, very engaging. I believe they are committed to working with states and being flexible. And so I think Kansas has a good chance of retaining this money and getting the next tranche of money. So then yesterday, we met with KREA, that advisory group. We gave them an update. We went over what our initiatives were. We shared documents like what the grant application will look like and so forth. And we're moving forward with them, and we'll keep them on a regular cadence of meetings and communication. Half of that $50 billion award, which was the total award, $25 billion was distributed evenly to all applicants. So every state got something, even though they might not be rural, which is kind of interesting. The remaining half was distributed based on rural factors. And for Kansas, we believe that's why we got the $22 million extra. We have a lot going on that they were looking for in the grant. We have a lot of policies in place that you all and the governor have supported. The interstate compact for providers, for example, physicians, was one. Some of the other policies we have in place check the box positively for Kansas, so we did get more money. So on page 8, it outlines how the funds will be expended. They have to be expended by the end of the fiscal year. So already we have to, when I say expend, because I made this mistake in another meeting, they have to be allocated this year by the end of, is it July? July. The end of July, we have to say they've been allocated. We have to spend them by September of '27. So we have that long to spend them. There are reporting requirements, milestone reporting, fiscal reporting, and then you can see a list of non-compliance for use of the funds of the grant. I won't read them, but you can kind of see why we're tracking this, and we have, this is like moved up on the major initiatives for KDHE and the state, because we've got to manage this at a level. We manage a lot of grants. This one's a little bit more stringent and tightly managed. If we are in non-compliance, CMS has committed to working with us and saying, no, you really can't do this. We will have a weekly, if not daily, cadence of communications with them as this launches. And then if we don't do what we said, they basically take the money back, or they don't give you the next round. So that's not terribly uncommon. On page 9 is the list of the CREA members, so you can see what we've added on there related to, these are members that we deal with all the time. A lot of our motto on this grant is let's leverage what's already in place. And if we have initiatives out in rural Kansas, and we haven't had enough money or resources or whatever to expand upon them, then let's do that with this grant, rather than say, let's create 15 new initiatives. Okay, there are some new initiatives, but we're also expanding upon what's already there. The budget timeline is there on page 10 that I just talked about, related to when we have to expend, allocate, and then spend the money. There will be reports along the way, and that's what we know today. This is in a lot of they put out about a 40-page frequently asked questions document that they update. The other day, as we had our dialogue with the CMS rep, when we asked about a couple FAQs, she said, well, what do you think? She said, I'm just going to say right now, the FAQs aren't binding. So I think Kansas has an opportunity to help mold some of what they're not sure of. I wish CMS would come out and drive around rural Kansas personally and, get real hands-on experience. But I'm very excited about this for the state. I think it's going to be great. My goal over the next year is to make sure we have an infrastructure and a process and a governance process over this grant, which I believe we do. And it's got to align with CMS, because they are going to tightly control what we can do. Okay?
Madam Secretary, I think we both agree this would be a good time for questions.
That's fine.
So committee, any questions for the Secretary over the Rural Health Transformation Program? Senator Erickson.
Thank you, Madam Chair. Thank you, Madam Secretary, for being here. Just a quick question. When you considered stakeholders to be part of the group that gave input on this, was any consideration given to having legislative representation in that group of stakeholders?
The governor assigned the stakeholder groups related to what our work is, but our group have always felt we'll be given regular updates to the legislature. And so I can't speak for the governor's office, but we could ask them. Related to the meetings that we're holding, the CREA meetings, those are all live streams and on public square. So anybody can watch them at any time. And we'll be glad to give updates at any time. But I really do have to, that is assignment by the governor, so I'd have to redirect you to her, okay, on that.
And I understand that the second tranche, when will that, has that been awarded, the second tranche?
No, all the money's been awarded for year one. We will have to apply, let me see if it's on that timeline. Yeah, on late August of this year. So that's how fast this is moving. We'll barely get out of the gate with the first. In late August, we'll have to reapply for the money again.
So there's a real possibility, though, that there may be a new governor by the time that second tranche comes through, correct?
Yes.
Okay, thank you.
Yes, that's correct.
Thank you, Madam Chair.
And I say, my remarks about getting an office and infrastructure set up is because when the governor's done, I'm done, and I want to make sure it's ready to hand off to whoever the administration is, so. Any other questions?
Yes, Senator Clifford.
Thank you, Madam Chair, and thanks for being here, Secretary Stanek. Given my rural district, I share your enthusiasm for this program. One of the things that is a plague, a chronic disease plague, is diabetes. And I do have the slides from yesterday's briefing. The potential hospital measure was only discharge checklist utilization, and I didn't see anything in the clinical measures, although they're listed as potential measures. I'll give an example of what happens out west. We ophthalmologists want to see all the diabetics who have serious retinal disease. The clinics have approached us in the hospitals and they say, well, we want to buy a camera and we'll send you a picture and you can tell us who needs to be seen right away, who can be deferred. That raises all kinds of issues of liability, follow-up for us. There's an absolutely wonderful AI solution of a acquisition device in a clinic that goes to a computer and in minutes they get an answer about the need for referral. So that's a technology piece. And I know that's one of the 5 pillars, but I don't see here where those kinds of technology pieces get considered in this first round.
We have a detailed initiative list. I will go back and pull that and try to identify something along those lines. But I also would offer, since you are a physician, Dr. Bob Mosier is the medical officer for the CARE Collaborative that's been working on those measures and so forth, and maybe having a discussion. But let us pull, Ally will put, pulling the detailed initiative list so you can see the line by line, because that's the high level. So that's a very good point.
Well, I appreciate the pressure you're under, but if you need a way to get the funds in the field, got a pathway in eye care.
Okay.
Thank you very much.
Appreciate that.
Thanks, Madam Chair.
Senator Thompson.
Thank you, Madam Chair. Thank you, Madam Secretary. I'm just curious how you anticipate these monies being used. Would it be to attack some of the structural problems of the rural health issues, or just to, in other words, the number of beds in some of these rural hospitals, the Medicaid funding that is not necessarily up to speed to help fund those hospitals? Do you have any specific ideas? I'm just very curious.
Yeah, well, so there's different categories: technology, workforce, transportation. Those are some. I can't. You have the presentation, so I don't have them off the top of my head. Some of this is not so you can get a new roof on your hospital. Or okay, that's the disallowed. Now, if you needed to expand because you were putting a new CT scanner in or something, there's possibility you can do some renovations, but they're very limited around that. I can't emphasize enough this is about the delivery system and not just the provider in one place.
Okay.
In fixing and saying we could add more beds. We are looking, one major initiative is on community health workers. These are people that are native to different communities or cultures that help facilitate. They're not necessarily clinical. There are people, and to train more of them. We have a robust training program at the KDHE and within the state. We've partnered with KU, and we also have some training that K-State has a cooperative to get more people in the field, to have health workers out in the field to help. Now, the other thing you can't do is you can't supplant federal dollars that are already being, so if you're already being paid through Medicaid for some service, you can't say, okay, we're going to add on top of that. It's got to be one or the other. So because this is so new, even if we think we might have an idea that brushes up against that, we would have to run that by CMS to say,
Okay.
does this qualify?
I was just curious, in some cases, it sounds like it, may be a Band-Aid, but a welcome Band-Aid. In some cases, it may be, and we need to look at the deep structural problems that are why Western Kansas has
Right.
healthcare delivery issues.
So one comment I'll make related to yours, you probably know that hospitals can convert to rural emergency hospitals. It's a different designation, it's a different reimbursement. It's a way to keep critical access hospitals in the rural areas afloat. A lot of hospitals don't venture down that because there are expenses with that. They don't have the resources, they don't have the people to try to get the application in with CMS. Sometimes structurally, their facility doesn't meet the requirements of a rural emergency hospital. We have designated dollars to help provide technical assistance to these hospitals to get them ready to apply to CMS to convert.
Okay.
So that would be one example.
That kind of helps answer it. Thank you.
Yeah, there's so much more. And so again, I'll offer again, if there needs to be a more detailed presentation, we'd be happy to do it.
Committee, additional questions? Yes, Senator Holscher.
Thank you, Madam Chair. Thank you so much for being
Uh-huh.
here. You may have mentioned this, and maybe I missed it. on page 7, CMS awarded the total amount, 898,000, no, 220, oh my gosh. A whole lot of money.
Almost $22 million more than we asked, so.
Sorry, I don't have my glasses on. And then it says it was the 6th highest award of all states. Can you tell me, in terms of, was there something that prompted it to be this, that Kansas was the 6th highest award? I guess I'm trying to figure out what the factors were
I think,
in terms of that.
yes, very strong application for one thing, and I would say the CARE Collaborative worked very hard with us to submit the application, the detail that was in that. But I also commented earlier, there were a number of factors, rurality, policies you had in place already, things that were favorable to, quite frankly, Make America Healthy Again agenda.
Yeah.
And there was a number of those that weren't anything we had to do other than say yes, no, submit the policy, get the federal delegation to support Kansas's application, things like that. We had a lot going in the right direction, and I credit, again, the legislature, the governor, and our stakeholder groups for helping us have a lot of those programs and policies in place. And personally, that is what led to our additional money. Yes.
Thank you for those specifics.
Strong application, yes.
Seeing no other question, I too would like to congratulate you and the team. Our only disappointment, as you know, and we'll be hearing more about this in your presentation to Bob Bethel on the 23rd,
Yes.
was our request that there be legislation or legislators involved in the process. In touching base with CMS on this very issue, they also said that things were in order and that you all did a really good job of getting things that were requested turned in. My one question is, January funds are available. This is January. Are there any funds that are being spent?
No. Right now, that term is, we can see it in our portal. You probably might know this, but a refresh if you don't. When we're given any kind of money from the feds, we don't like have it in the bank. We get it, we draw it down and distribute it. We get it like a reimbursement. So it's a drawdown process. So right now, we can't draw down because that meeting on the 12th, which was Monday, they told us what we needed to change in our budget. Once we turn that around, January 30th, our budget revisions are due. They committed to speed up their normal 45-day process that I mentioned earlier to say yes, no, whatever. Once that happens and we have an initiative and we say this is what we're going to do and how we're going to do it, and they say, okay, we can draw down. But we can't draw down we have to draw it all down by, or get it allocated or assigned no later than July 31st. Mm-hmm.
Thank you so much. Please
Yes.
continue.
Okay, so the rest, I won't read every line, but going to go over the Division of Public Health. Obviously, we do a lot in public health. We promote and protect health and prevent disease and injury amongst Kansans. On page 12, there are a number of bureaus. And again, I know some of you have come over to visit KDHE. If the door is open to come over and get a better firsthand look and meet our directors if you ever want to, related to the different bureaus and areas that we are responsible for overseeing. And so there's a number of them. And all states do this a little different, so that's why I think it's important for you to understand what we have and what we don't. We don't do food, for example. Ag does food, but people think we do food. We don't. So page 13 starts detailing out what each of those bureaus does. So the Bureau of Community Health Systems, an example with this grant, they already do a lot related to rural health and HRSA and the loan repayment for physicians and other providers going to underserved areas. They will tie in and we will leverage what they do already with this grant to use those resources. And if we don't have to hire more additional staff, we will leverage that, for example. We also are responsible for licensing. We don't do the nursing homes pieces, that's KDAD's, but we do a number of hospitals, transplant centers, the critical access hospitals, all of those licensed agencies listed there are what KDHE is responsible for. And we carry out the licensing requirements, starting with the federal level and then the state level, but the feds guide that. CMS is the decision maker on those areas. On page 14, we have epidemiology and public health informatics. This is where all the disease tracking, when you hear about measles and tuberculosis and so forth, this is where all the epidemiology work is. Health promotion is about wellness. This also area ties into MAHA, Make America Healthy Again. And this area will also be very critical to the Rural Health Transformation Grant execution. On page 15, that's where our disease control and prevention work is. Those are the people that go out and track people with communicable diseases and all the things that we've dealt with that you've heard about, the vaccinations and so forth. Then we have a dental officer who's overseeing the Bureau of Oral Health. On page 16 is the Bureau of Family Health. That's where the WIC program and pregnancy initiatives and so forth related to disease screening for moms and so forth lives. And then as of 2 years ago, we moved the lab from the environmental division back under public health. If you haven't seen our beautiful lab, if you're new, we'll be glad to provide you a tour. We already know some members of the legislature want a tour again. We do about a million clinical and environmental, not just clinical. We do environment, soil, water, et cetera, testing. We opened in about March of 25, and we are on the corner of Topeka Boulevard and Harrison. Related to slide 17, local health departments are a big part of the Division of Public Health. We are what's called a decentralized state. We do not run the health departments. We fund them. We pass through money to them, and they rely on us, but they are independent, and they, for the most part, I think we're aligned, but there are times when they have individual decision-making power in their various communities. Their commissioners normally are the overseers of local health departments. We've worked really hard at making sure that with CALD, the Kansas Association of Local Health Departments, and some of the commissioners, that we are working together to try to make sure that we're, I guess, optimizing on all of our public health resources all throughout the state. It gets more tricky in the rural areas, as you know. The state workforce is outlined there of what the local health departments in Kansas look like. A little over 1,200 full-time employees in the 100 health departments we have. We have an average number of 13 employees. We have one employee in one department, and then we have one health department with 170 employees. So you can kind of just see that to understand the landscape in Kansas. Some key accomplishments, in 2025 for public health. We ended the measles outbreak. We ended the tuberculosis outbreak. The lab I spoke about already. And we thank you for the passage of Senate Bill 126, which updated the newborn screening cap to allow for more programs and more tests to be run. And we increased the state formula funding in statute. So the health department's got a certain amount of money. That was capped at a certain amount. It went up, and we appreciate you doing that as well. There's a need for continuous funding, as you know. Some of the goals for 26, we are moving the Kansas Office of Vital Statistics out of the Curtis building to make room for Kansas Highway Patrol to a new location. And so we will move after July of 26. Staff has been informed. We are looking for a customer-friendly location and so forth, and we think we've identified something that will work. We are working, the Department of Administration, as you know, is the lead on that, and we work collaboratively with them. There is money in the budget to do that as well. There's a grant I'll talk about when I talk about Medicaid called TMA. It's called Transforming Maternal Health. Well, Medicaid can't do that alone, so the Public Health Division will continue collaborating and working on initiatives there. You know that the Governor's Office of Early Childhood was established. That means about 54 people from KDHE will move under that new structure and out of KDHE. So we are working right now on a number of initiatives to transition and make that smooth. And then the World Cup is coming, as you know, and we play a big role, big role there on preparation, guidance, and response for that. And obviously, disease outbreaks and so forth are a big. We have to unfortunately prepare for the worst. So we're working with KDEM and so forth on that. And then obviously, public health will be front and center in supporting the rural health plan grant that I just talked about. Before I go on to Medicaid, are there any questions about public health? And I have Ashley Goss here with me as well, our Deputy Secretary.
I will go ahead and jump in real quickly. Back to the rural health, because it's something that was just brought up, is that you mentioned it as a system. And my understanding is that once these funds are no longer going to be offered, because it's not a perpetual, it's over a period of time, that the system is to continue, so it's not to be dependent upon federal funding. Could you explain that?
Well, they want you to present sustainable projects, right? So they're going to be looking at that. So one thing, I'd give an example of maybe something that in Medicaid, we started to pay for some, or we're proposing some EMS reimbursement, you know. That's a thing where, that's one of the issues we have is transportation, particularly in the rural areas. If we can get it up to a point where we can get a code that's reimbursable to the point it would sustain, and EMS providers would be more attracted to, you know, grow their services or enhance their services, and we could set it up where it's self-sustaining from a reimbursement perspective through the Medicaid program down the road. I'm talking about 5 years. That's an example of what would be acceptable. Totally understand your question, because that's exactly the challenge of this grant. You can't do something that's not going to be sustainable, so you've got to figure out what the reimbursement and so forth, and how you're going to demonstrate the ROI on that. And the feds, not just you all, but the feds are going to be looking for that as well.
Yes, go ahead, Senator.
Thank you, Madam Chair, and thank you, Madam Secretary. How would you describe the health of the people of Kansas currently? Is it getting better or worse? And do you anticipate this grant to improve the overall health of the people of rural Kansas?
Yes, that's the intent. The intent is not just to provide them with delivery of services, it's to improve. That is a very tricky question, because a lot of people will go to the American Health Rankings, right? Their new results just came out. We've gone in the last 2 years from number 29 to number 27. We just found out last week we're 27, okay? So that's great, but what does that mean? Because some of those rankings, it's in the eye of the beholder. Rankings on a national report take years to develop and to see the results. You could put a program in today that might take 5 years to see the results. So line by line, I suppose, different areas, we could tell you how we're doing in different key areas that we focus on. I don't have those statistics in front of me, and I'm not in a position to say, I don't think we're a D or anything, but in some areas we might be. In other areas, we do well. Ashley, do you have anything to add to that? No? Okay. So could I follow up with you? Okay, thank you. Good question.
Yes, go ahead, Representative.
Thank you again, Madam Chair. I like your thinking on the rural ambulance subsidy, and I agree it has to be sustainable. Where I live, you know, a quarter of the emergencies aren't transport, so there's no reimbursement. But to sustain it, would you not need to do then a plan amendment with CMS? I mean, is that would be the long term?
Yeah, there's all of that goes with it, and we've actually taken this apart on all of our initiatives, and now we're trying to, you know, we're figuring out a tracking system and whatnot. What needs a statute change? What would need an amendment with CMS? What would need legislative approval? You know, there's some of, and what would need nothing? Because some of this, and some of these initiatives, by the way, won't be the state constantly saying, hey, we need to do this or that. Some of these initiatives will be handed off to partners. The PACE program is a great example. We don't run PACE. KDADS does, but then KDADS might offer a grant out to a PACE provider to say, we need you to establish additional services or expand somewhere. And so then some of that will be on them. It's all over the place, to your point, though, and we've been working on this nonstop since July, even before we got the grant, to try to get ahead of those types of things. We had a punch list of items, and so you are on the right track, and more to come as this rolls out, is all I can tell you right now.
Thank you, Madam Secretary. Thank you, Madam Chair.
Thank you, Senator Clifford. You answered or you got my question answered by asking my question. You mentioned the new division. How many FTE are you needing for this new division, and will that be paid out of the funds from the transformation
Yes, it will be
fund?
paid out, and it won't, we're going to leverage our existing staff. Right now, our acting director for this is my chief of staff, and my plan is to keep him doing dual role, Matt Lara. Then we have already people that submit the grant this is a grant management system from CMS. There's a whole process. Fiscal team, maybe we'll hire one person. We are looking maybe at one procurement person, maybe into next year. Secretary Howard may need to hire a couple, but those will all be funded through the grant. So it's not any additional dollars to the state.
Okay, thank you. Please continue.
Okay, I'm going to jump into Medicaid. Christine is traveling, but I think I can cover this, and I know we have Bethel coming up and whatnot, but if I can't cover it, we will follow up. So for those that are new, DHCF is Medicaid. It's an old carryover term from when Medicaid was in a different division. But we do operate the Medicaid and CHIP, Children's Health Insurance Program, very heavily federally regulated, as those that are on the committee know. We oversee, the Medicaid program is overseen jointly. We are the sole agency at KDHE. That's a designation you have to have as a state by CMS. But KDADS has a large component of Medicaid as well. We do all the requirements that are for the federal government. We have to make sure everyone's in compliance no matter whether it lives in KDADS or KDHE. KDADS has the aging and disability, the home and community-based services, which you hear, all the waiver programs, behavioral health, and long-term care. And then again, we have a lot of oversight we do related to the program in general. Medicaid and CHIP are a partnership between the state and federal government. The state designs the programs per federal requirements. There is flexibility to address populations for services that meet Kansas-specific needs, and I know that some of you on Bethel are familiar with that, know what I'm talking about. We're required to comply with those to get funding. The federal government, the good news about Medicaid, pays roughly 62% of all the Medicaid funding that's in Kansas. Those are medical costs. 70% of the CHIP, that's the children's program costs, and between 50 and 70%, and this depends on the program, of associated personnel, contracted services, and IT. So if we have an IT adjustment in one of our systems or need to buy an IT system to meet one of the federal requirements, they will fund part of that. And we do, and that's not just for Kansas, that's for all states. So it's quite the tracking system we have to have in place. Statistics in Medicaid are a moving number, and we track these every month. And these are in arrears because of claims processing and whatever. But as of November, we are at 398,101 Medicaid enrollees, and it's broken down there by Medicaid CHIP, and then what's called M-CHIP, which is the Maternal and Child Health Program. That's a little lower than you might have heard last year, and even a couple years ago, and during COVID, we were close to 500,000. But we're hovering around that. So on page 24, there's an outline of who's eligible for Medicaid. So it's known as one of those, the old term of the government entitlement program. And there are enrollment requirements in different coverage caps on the programs. A person must be covered, have to be covered in the program as child caretaker, pregnant, disabled, or elderly. There are residency and citizenship requirements. You hear a lot about that in the news now and then with HR 1, so very aware of that. And then there are financial thresholds, and the state controls some of those. They vary by different categories, so I can't even just tell you it's one number because it depends on which one of those groups you're in. Medicaid at KDHE processes the applications for Medicaid and CHIP. And then the DCF, Department of Children and Families, processes the applications for the other public service programs that are under Medicaid, TANF, which is the Temporary Assistance for Needy Families, and then SNAP, which you're familiar with is a supplemental nutrition program. On 25, there is an outline of services covered by Medicaid, and I won't read all of those unless you want me to, but there are mandatory services, and then there are optional services that states are allowed to cover. And so example of mandatory would be hospital services in the inpatient, outpatient setting, physician services, lab, x-ray, and transportation. And optional would be certain drugs. We have a drug oversight, a formulary oversight committee, hospice, podiatry, and durable medical equipment, and I'll talk about that in a minute. We are what's known as a managed care state, which is basically 95% is managed care. That delivery system basically entails us outsourcing the management of our program to 3 different what's called managed care organizations, and those are insurance companies. And right now, those are Sunflower, which is Centene, Healthy Blue, which is a subsidiary of Blue Cross, and then, I must be, United. I'm sorry, United people that are listening. Yes, I should know that. So, there are some of our populations that are not in managed care. Medican, PACE, and tuberculosis program. That is a separate program in Medicaid. They're paid fee-for-service when you pay as you go. You go to the doctor, you pay it. Managed care, it's more the total cost of care, and there's an allotted a dollar amount, and you make it fit in there, or you don't, and that's how profits and losses are gathered, and we go from there. On page 27, we have some accomplishments, and Medicaid has a running list of many things all the time because some of our initiatives and accomplishments are based on what's required by the federal government for us to have in place, and others are things that are programs that come to us through you all, through our stakeholders, and so forth, and to do the right thing to make patient care better for our Medicaid recipients. We did go live a year ago already on what's known as CanCare 3.0. That's the 3rd contract during a managed care, our managed care inception since 2012. We basically did a great job on that, and I'll give kudos to all the staff that was involved and the MCOs. We were a month ahead of schedule. There's hiccups like there is in anything, but we have really made great strides and a commitment to, in this 3.0, to manage this contract at a level that has probably not been done because of time, resources, and whatever, no one's fault. We restructured a clinical unit for the purpose of enhanced auditing of our program to look for cost efficiencies, focused partnership on education with the MCOs on things like the early periodic screening, which is required for children. And then we conducted our first in-depth utilization management audit of the managed care plans to make sure that we were identifying efficiencies that we could implement and streamline service delivery. We also made enhancements to service level agreements we have in place. We've had service level agreements. We haven't always managed them well because, again, of resource timing and whatnot. We have reviewed our required reporting from the MCOs. We have worked on data to enhance and improve the member experience and outcome. And then eventually we will expand to incorporate HEDIS, which is the health, data information system, basically core measures that we have that we're required to have to measure outcomes, clinical care, et cetera, and other quality managers. One thing we did is implemented what's known as the hub, managed care hub. I think that that's going to be presented in Bethel next week. And this is basically a hub where we can conduct oversight of all the managed care plans across the continuum of Medicaid, not just that KDADS is doing their thing, KDHE is doing their thing, or Program X is doing their thing. And we're going to speak to Medicaid as one voice. So it doesn't matter if it's split up or if I'm one secretary and Laura Howard's the other. It's going to be one Kansas, and that's the name of our hub. We were awarded on page 28 and recognized the best use of technology customer by IT Solutions Management for Human Services. And that was based on all of our work that we're doing in our electronic ability to enhance communications through text, phone, chat, et cetera, with Medicaid eligible clients. The Transform Maternal Health Grant, TMA, that I talked about, and you'll hear a lot about TMA, but I wanted to make sure you knew what it was about. We were only one of 15 states awarded $17 million over 10 years to improve maternal and child health care for Medicaid and CHIP members. It began its 3-year implementation phase in 2025. The focus is on expanding access to non-traditional care providers, facilities, strengthening infrastructure, reducing costs, et cetera. And this is where public health, as I noted earlier, is collaborating very heavily with the Medicaid program. We also have been collaborating very much more with the Office of Inspector General and the Department of Children and Families to identify opportunities to enhance data sharing across agencies for multiple purposes, discussed additional ways to prevent fraud and abuse, and I know that continues to be a question. And then we continue to do Medicaid fraud training. The OIG has helped with that as well, and he's been very helpful related to offering his services in that regard. And then we have a work group. We have a chief medical officer over KDHE, but then we've got our largest clinical infrastructure in the Medicaid program since in many years, where they are actually one medical team managing, and we hope to expand that further into the KDADs this year. So I'd say back to my goal at the beginning of this, to break down those divisions and have us function as one. We're working on that, the goal I mentioned. Some future goals for 26 is, again, TMA, that grant will be executed on. There's a number of items there related to expanding telehealth, remote monitoring, and so forth. Again, where does the new grant come in? We're not sure, but again, we want to leverage that. We want to have interprofessional consultation billing pathways for non-physicians, and you'll see the midwives, primary care, behavioral health providers, and other. And this grant allows us to do that. And again, this is one that for a while CMS was a little slow to get it started after they awarded the money, but we are very focused on that now. There are some new requirements with GME, graduate medical education, that are coming down the pike through HR 1. And we're not sure what those means, but right now we are completing work with some work groups on the EP-STD, which is a requirement and a very important screening tool, and that's misunderstood by many providers, but very powerful, impactful to patients. We are going to use a foundation of data development to improve our efforts in preventing and addressing the fraud, waste, abuse matters as well. Again, I talked a lot about how we're managing and resourcing the oversight of the contracts and our membership, et cetera. And then Medicaid, again, is on the core committee to execute on the Rural Health Transformation Plan grant. So lots of stuff. Bethel gets a big view of what's going on there as well, and I'll try to answer any questions I can or take back what I can't. Thank you for your time.
Madam Secretary, I have invited of course, some of our members serve on the Bob Bethel Committee, but invited our members to be able to watch the Bob Bethel, or at least go back and view it. I have a couple of questions, and I'll open up the committee. How long from application to determination are we seeing now with those who are applying for Medicaid?
I can get you that number. I can assure you it's under the required time frame. We are doing very well in that regard. So I will get you that.
Great. Thank you. I'd appreciate that. We'll share that
Yep.
with the committee.
Yes.
And then also, how often are we auditing continued eligibility?
All the time, because there are new requirements for that. And I just screened the Bethel slides, and I wish I had those with me, and I apologize, but you'll get an update on that, okay?
And you'll share that in Bob
Yes,
Bethel?
and it's continuous,
Excellent. Senator Thompson.
Thank you, Madam Chair, and thank you again, Madam Secretary. This is kind of out in left field. This doesn't really have to do with what we've discussed here today. One of the big concerns in the environmental side is where we've had some wind turbines disintegrate and spread, the fiberglass resin across cattle farms and things of that nature. And I didn't get a sense from the farmers out there that they got the response from KDHE that they really wanted. If there's an oil spill, that's a clear environmental issue that you're used to dealing with. But this is a kind of a new thing, and it's going to become more of a problem as these wind turbines get older. And, you know, how does KDHE monitor the cleanup, require the cleanup, make sure that the land is cleared and the water sources aren't contaminated by this stuff that can be very harmful to people and to the animals?
Right, I've heard a little bit about this over the last session, actually. I'd like to get my Deputy Secretary of Environment to give us a summary. I will tell you that up until maybe the disintegration water area, we had really no, I don't want to sound like we don't care.
It's a new thing.
It's a new thing. We aren't responsible for wind turbines, and people think we are, back to the environment. However, back to pollution, ground, and whatever, that, I'm recalling that's like a team sport among many. It could be ag, it could be corporate commission, it could be a number of people. So I will follow up on that and give you a summary as to what we've been involved in, what we see our role as related to, not because we're picking and choosing, but
Right.
statutorily. And then we'll talk from there, if you don't mind, if I can.
I appreciate that. And with, you know, to the extent that how you can hold the LLCs or the companies that have these wind turbines accountable for the cleanup, I think that's the big concern.
Okay.
Because they seem to be able to just walk away and wash their hands of it, and I don't think that's a good thing. So I would appreciate a response on that.
Okay. Yep,
Okay.
thank you. Uh-huh.
Thank you.
We'll do that.
Senator Holscher.
Thank you, Madam Chair. Thank you so much again, Secretary. In terms of transforming maternal health, are there any details you can provide in terms of anything addressing maternal mortality rates? And this can be something new forward later, because I
Okay.
know we're running low on time, but I'd
Yes,
appreciate
yes,
that.
we can make sure that that's in there. That'll be part of it, of course, and, you know, we have a whole committee on that.
Yeah, I'd just like some of the
Physician-led.
details.
Yes, we'll get you that. Yes.
Senator Clifford.
Thank you, Madam Chair. This is a get back to me question. I've been reading a lot about fraud within the autism space, and a lot of state budgets are seeing a rapid increase in payments for suspect treatments for autism. I wondered if somebody could get back to me with the numbers and what we're paying for autism treatment.
Yes, and we do know that's on CMS's radar as well, so I'll have to get back to you.
Thank you, Madam Secretary. And very good briefing. I'm exhausted listening to you. Thank you, Madam Chair.
You got a long ways to go, man.
If you're exhausted, serve on Bob Bethel, which is an all-day committee on this, on Medicaid oversight. Just teasing. And committee, again, reminder, we will not be meeting tomorrow. And thank you so much, Madam
you.
Secretary,
Good
for your
seeing you all.
presentation today. We will be getting a copy of the presentation that was made or the briefing that was given on the 12th, and that will be shared with the committee.